Because you may find a lot of variation. It means you have some weakening of the vascular wall that can bring to aneurysm. In this case, for sure, the aneurysm was rising from this area, and this is the trigeminal artery. And so, no doubt that the clinical presentation were mostly like coronary sinus syndrome. And you can treat it, or it can bring you to some kind of other disease. This is example of the case that we have. We have this, imaging of the too many vessels in the coronary sinus, and it's in different density as a signal as the carotid itself. And it's extended probably arterialized things around this area a little bit posterior to the coronary sinus. So what we can think about when you see this is that you see this artery and the shunt was exactly there. So that means you can expect to see this angiogram. That you see something like the shunt, quite high flow shunt at the coronary sinus level, that you may think it is just what you see as the CC fistula. You see now you have this nice regular picon, and this is the injection of the vertebral artery. You see that this is not like what you can see in the regular CC fistula, because this connection is much lower than what we expected at the top, like feeling from the pecon. So you think about the variation of having this trigeminal artery and fistula was seen from that level. So most of the time, this is not changing much your practice, because some of the cases you can go with transarterial, just knowing that you are dealing with a hole that is located there, and there is another connection to the posterior circulation by trigeminal artery. And for sure, when you were able to get rid of the pathology, there is a remnant of this artery seen there. And no more shunt, is that this is a possibility of the disease that can be related to this persistent trigeminal artery. Either is first, this aneurysm, secondly, it can rupture or into this kind of fistula. Even in some cases, I was seeing this and I was trying my best to go transarterial. And if you analyze it very well, you see this, okay? And by injecting vertebral artery, you have this classic shape of the trigeminal filling up the fistula over there. So by that time, I was not able to go transarterial, so it's not too bad trying to find the other way of treatment. For example, we go transvenous and trying to pack all, and this is after treatment, you see this classic trigeminal artery without any more shunt. So this is example of disease that you can see with the trigeminal artery persistent. Is there any question related to the disease that can happen to trigeminal artery? You have microphone?
I was just gonna ask if are there any perforators that arise off the persistent trigeminal artery that would be of concern? Like for example, like PCOM will have Allen perforators or P1 segments, and if this is a similar distribution of providing those territories, are there any perforators to be concerned about?
So far, what I've known, I don't think we have perforators, but there are rare reports of aneurysm at the junction of the fascia, which is very rare. In that situation, you may have the subarachnoid location of the reading or aneurysm located. But I don't think there are perforators coming from the trigeminal.
Very nice. I mean, they're clearly nice examinations, examples of a trap that you can find yourself into if you don't think about the possibility as an aneurysm being associated with the trigeminal artery. Anybody has a personal experience having a case like that?